Hello everyone, this is Dr. Kriti Jajani. Welcome back to my YouTube channel Speedy Dentistry. Today we'll be learning about osteoradionecrosis. Osteo stands for bone, the radiation and the necrosis. In this, the irradiated bone becomes devitalized or exposed through the overlying skin or the mucosa, persisting without healing for 3 months. That too in the absence of any tumor recurrence. So osteoradionecrosis stands for the irradiated bone which becomes devitalized or exposed through the skin or mucosa, persisting without healing for 3 months, that too in the absence of tumor recurrence. Next, we'll study about the etiology. For etiology, two pathogenesis have been stated. First is 3H theory, that is the Marx theory, and next is Meyers theory. In Meyers, there is RTI, that is radiation, trauma, and then infection leads to ORN, that is osteoradionecrosis. In Marx theory, that is the 3H theory. 3H stands for hypocellularity, hypovascularity, and hypoxia. In this, radiation has 3 effects, that is cell death, next is cell damage, and third is vascular damage. For cell death, bone cells die after the radiation, which leads to hypocellularity and further leading to tissue breakdown and finally ORN. In cell damage, loss of reparative and synthetic functions leads to ORN. In vascular damage, endarteritis, obliterance, and thrombosis occurs, which leads to hypovascularity, leading to gradual ischemia and further hypoxia, which in turn leads to osteoradionecrosis. For the risk factors, in risk factors, radiation of more than 50 Gray or the brachytherapy, ortho-voltage radiations, advanced cancer and recurrent cancers, also the caries or mobile teeth, any bony spicules, and immediate post-radiation or during the post-radiation if we have performed the extractions. So the risk factors are more than 50 units of radiation, brachytherapy, ortho-voltage, any advanced or recurrent cancers, and the caries or mobile teeth, any bony spicules left, and the extraction performed during or immediately post radiotherapy. For the clinical features, there is severe, deep, boring type of pain. So the pain type is severe and deep. Also there is trismus, since the muscle effect is also seen. Trismus, swelling, any soft tissue abscess can be seen, draining sinuses or fistulas are present. Also the exposed bone is the classical feature. And if any plate has been placed, then plate exposure will be there. Bad odor will be there, that is fetid breath, and pathological fracture chances will be there since the bone is weak and devitalized and exposed. The radiation also affects the oral cavity, that is radiation caries occur. There is dry mouth and mucositis. Also food lodgement is commonly seen. Next is the diagnosis. For the diagnosis, there is history of radiation. The patient will be presenting to you with the history of radiation. Also, the clinical features mentioned below help us to diagnose the ORN. Any radiographs, that is the OPG, CT, MRI will further help. Also, there are early changes and late changes. In early changes, the CT, MRI doesn't show any significant changes, so there is no changes. In the late effects, there is sequestrum, which can be seen, and pathological fracture. Now comes the management. For the management, we have 2 goals, that is we have to revascularize the bone or the excision of altered bone. Either we can revascularize the structure or we can excise the structure. For revascularization, we perform non-surgical treatment, that is we give the pain relievers, any narcotics and nerve blocks can be used. Also we do local wound debridement or packing in case of fistulas. Antibiotic therapy we prescribe, HBO therapy, ultrasound therapy, and the nutritional therapy. These all will lead to revascularization of bone. Now for the excision, we have to perform the surgery, which is sequestrectomy or bone resection. There can be intraoral approach or the extraoral approach. For intraoral approach, suppose this is the alveolus. For intraoral approach, we give the incision at the alveolar crest, and then we reflect the flap. We make holes with using the micromotor, and we wait till the fresh bleed occurs. Fresh bleed will signifies the vital bone area. Using the giggly saw, after that we osteotomy the site and make sure no bony spicules are left. Because if bony spicules are left, these bony spicules can be a etiological factor to again cause the ORN. Now for the extraoral approach, submandibular incision is given, and extensive, if the ORN case is extensive, we can perform mandibulectomy with disarticulation. Right, now comes the prevention. For prevention, extraction before the radiation should be performed. As we have seen, extraction during or immediately after radiation therapy will lead to ORN. So to prevent that, we can perform extraction before the radiation. For this, tooth in line of radiation, that is the tooth in line of fire, should be extracted, and also any affected teeth because of caries should be extracted. Also, we need to maintain good oral hygiene. Fluoride therapy should be prescribed, and after radiotherapy, if extraction has to be performed, it has to be atraumatic as much as possible. Also, we give pentoxifylline and tocopherol. Tocopherol is vitamin E, and plus or minus clodronate. Clodronate is bisphosphonate. So we give pentoxifylline 1 month before the extraction till the healing occurs in the dose of 400 mg BD. And tocopherol is vitamin E. We give 1000 IV units per day. And clodronate, that is the bisphosphonate. What bisphosphonate will be doing? It will decrease the osteoclastic activity, thus bone resorption will be decreased. We don't want bone to resorb, so bone resorption will be decreased. Now comes the hyperbaric oxygen therapy, that is the HBO therapy. HBO is breathing oxygen, that is 100% oxygen at the rate of 2.4 absolute atmospheric pressure for 90 minutes. This is one dive. Breathing 100% oxygen at 2.4% absolute atmospheric pressure for 90 minutes is one dive of HBO therapy. This dive is performed 5 days in a week, that is 5 days in a week. And 30 dives are given usually plus 10 dives. So what are the effects of HBO therapy? HBO therapy will decrease the infectious state. Infectious state will be decreased by enhancing leukocytic lysosomal activity. Also, neutralization of bacterial toxins will be seen due to HBO therapy. So neutralizes the toxins, leukocytic lysosomal activity is increased. Next, free oxygen radical bactericidal activity is seen against anaerobes. Since we have make the oxygen rich environment, anaerobes will be dead because of this. For aerobic augmentation in wound healing cycle, that is collagen synthesis is seen. Also, neo-angiogenic stimulation, new blood vessels will be formed, and increase oxygen will improve the ischemic area, that is the hypovascularity which was caused due to the ORN, osteoradionecrosis. For the application purposes, we'll again divide it into 2 and 2. Application for ORN, for osteomyelitis, for air embolism, carbon monoxide poisoning, mucormycosis, and to promote bone graft healing or flap uptake. So we are doing the HBO therapy for osteoradionecrosis, osteomyelitis, air embolism, carbon monoxide poisoning, mucormycosis, and to promote bone graft or flap uptake. Now, what are the contraindications for the HBO therapy? HBO therapy is contraindicated in C and I, that is the contraindication. C2, I2. C is for claustrophobia, patients having claustrophobia. Also, in cases of COPD, chronic obstructive pulmonary disorder, we contraindicate this HBO therapy. For I, patients who are immunosuppressive, who are having immunosuppressive disorders, and next I is for eye, that is the optic neuritis. So patients having optic neuritis, any previous immunosuppressive disorders, who are claustrophobic and are having COPD are the contraindication for HBO therapy. Next we'll be learning about the complication. For complication on brain, seizures will be seen. Seizures. Also HPNS, that is the high pressure nervous syndrome, will be seen as a complication of HBO therapy. Next, visual changes will be seen. For visual changes, effect will be seen because of the hyper oxygenated environment. Next comes in the sinus area, increased pressure will be there, so tooth pain or sinusitis can be seen. And for the lungs, pneumothorax will be seen as a complication, pneumothorax. So concluding the complication, oxygen toxicity will be there, seizures, tooth and sinus pain, visual changes, high pressure nervous syndrome, pneumothorax, and decompression sickness will be seen as complications. Next comes the MARX protocol. For MARX protocol, there are 3 stages. Stage 1, in which we give 30 dives. Now after 30 dives, if response is there, we give additional 10 dives. We have seen what is a dive. So 100% oxygen, more than 2.4 atmospheric pressure, absolute atmospheric pressure, and then we give this for 90 minutes. This is one dive. We give 30 dives, and then we see if the response is there, we give additional 10 dives. If after giving the 30 dives, we examine the exposed bone and there is no response. For no response, we go for stage 2. In stage 2, if response occur after the stage 2, in this we give additional 10 dives, and we see after giving the additional 10 dives or during, we perform the surgery and we still maintain the inferior border. So if this is mandible, we have maintained the inferior border and we perform the surgery maintaining the inferior border, and 10 dives are given. If still there is no response, we stop this HBO therapy. If after these 10 dives no response is there, then we go for stage 3. In stage 3, we perform resection and fixation with reconstruction plate, and also we give 10 dives. So 10 dives we have given here and during this. So in stage 3, resection and reconstruction is performed. Also the reconstruction after 3 months is done. If any bone knee reconstruction we are planning, that is done after 3 months. The third case is if the cutaneous fistula or any pathological fracture is present, or resorption of inferior border of mandible is there. Inferior border is resorbed, pathological fracture is there, or cutaneous fistula is there, then we directly go to stage 3. So we have stage 1, stage 2, and stage 3. In stage 1, there could be response. That is, in that case, we give 10 dives. And we examine the bone, there is no response, we go to stage 2. Here we perform surgery maintaining the inferior border. If response doesn't occur, we stop, and if it occurs, we give 10 dives, and after that, if there is no response, we go to stage 3. In stage 3, resection and fixation with reconstruction plate is performed and 10 dives is given, and for reconstruction, complete reconstruction, we wait for 3 months. For the third case, if any cutaneous fistula is present, pathological fracture is present, or the inferior border is already resolved, then we directly go to stage 3 of the MARX protocol. Thank you for listening. Stay tuned for more. Please like, share and subscribe to my channel, Speedy Dentistry.